For the last 20 years, we have been trying to educate health professionals and women that they are at risk for cardiovascular disease at different times during their life. And we have been fortunate in that we have the heart disease and pregnancy program where we see women with all types of heart disease through pregnancy. And at that point, we can warn them or caution them about later problems that they could have regarding cardiovascular disease. But that is a unique opportunity, and we have a unique program to offer this care. We've cared for nearly 4,000 women in the heart disease and pregnancy program. And many women will manifest heart problems for the first time during pregnancy because of the hemodynamic challenges of pregnancy, or women who were born with heart disease, or congenital heart disease, or valve disease, or cardiomyopathies, or arrhythmias. They may wish to become pregnant, and we need to do that in as safe a manner as possible, rather than just saying pregnancy is not a good idea. What this has evolved into is a program that really spans the cardiac health care needs of women of all ages. And so it's very important that women get the message early on that they could be at risk. But certainly as they get older, they need to get more proactive about their health. We need to identify the conventional risk factors, which certainly affect women. Plus, they have additional problems when they go through menopause. That's when the playing field becomes very level, and the risk for a woman for a heart problem is very similar to her male counterpart of the same age. So we're trying to get those messages across. We've been doing, for the last 9 years, we've been doing symposia, educating health professionals with the current information that's available. Now, many years ago, there wasn't a whole lot available, but we are very fortunate as there's more information available, there's more data available that is really gender specific. And it's really an exciting time here at Northwestern because we've identified, not only in cardiology, but in other subspecialties, there are gender-related problems and populations of women that we're serving that are outside the sort of standard realm of OB-GYN. It really depends. Women who have complex congenital heart disease should have a cardiologist who is an expert in adult congenital heart disease. It's very unusual. The pregnancy programs are very few and far between in this country, so you don't always have that advantage. That's why I see patients from all over, and we come up with a plan, and then that can be implemented by their local doctor. So, I mean, a woman who lives in Iowa is not going to stay in Chicago for 9 months waiting to deliver her baby. So what we do is we'll work with the doctor in Iowa or in Indiana to give them a plan and say, if this happens, do this, and this is when you call your cardiologist, and this is what to expect. But we try to do that, especially in our adult congenital program, when they have a general cardiologist and they may want to see a specialist once a year just to touch base on what's new and certain things to be looking for that are different than the general population. The patients appreciate that because they don't have to explain their disease every single time they walk in the door. The field of pregnancy and heart disease has advanced because we are more comfortable with severe illnesses during pregnancy, and we know how to manage them. We are at a disadvantage because you can't do controlled randomized trials in pregnant women. It's just not ethical. And so we sort of manage the patients by herd statistics, by expanded case reports, and expert opinion, basically. And I think the expert opinion is getting more expert as time goes on. And I think people are getting more comfortable with certain types of heart problems. We also have other alternatives now, and better alternatives for people who want to have a family, but for whom it's maybe dangerous to have a pregnancy. Adult congenital heart disease is expanding just like cardiology with interventions and the surgery. Every generation, the surgery for complex congenital heart disease gets better. And I have patients who are like third, fourth generation of complex congenital heart disease repair. You can hardly tell when you look at their echoes that they have had anything done. So that's all getting better. Surgery's happening earlier in childhood. And so these children are growing up with more normal ventricles, and of course then they want to do everything everyone else does. They want to work, and they want to exercise, and they want to have a family. Northwestern is really the ideal place for me to do what I'm doing with the high-risk OB, because the high-risk OB here is phenomenal, and they are very advanced. They do some great research, and they're very open to working with us. We have a relationship with Lurie Children's Hospital. So as far as the adult congenital, we're seeing the survivors, so to speak, from Lurie, and a lot of them in the pregnancy clinic, so there's that connection. And then they sometimes stay at the adult facility for their extended care. We are uniquely placed here at Northwestern because we are, literally across the bridge from Lurie, across 2 bridges from the Women's Hospital. So we can provide care, and there's nothing that we are missing as far as that. There's no instance where we need to refer somebody to somewhere else. So people can get all their care here. That being said, we are also willing to work with local physicians if we think it's safe, and we come up with a plan so that women are more, especially pregnant women, don't have to be, running all over the city when it's time to deliver.